The U.S. Senate Special Committee on Asia will now come to order. Last year, this committee exposed the public health risk and national security threat posed by America's over-reliance on communist China and India for generic drugs and the drug ingredients that make them known in the medical industry as APIs. Together, Ranking Member Gillibrand and I led a bipartisan effort to demand accountability. We sent letters to the Food and Drug Administration, the Department of Veteran Affairs, and key industry stakeholders, including large drug purchasers, distributors, and major pharmacies. The Aging Committee sounded the alarm and exposed the dangers in Americans' medicine cabinets. Our committee also released a bipartisan report detailing the extent of these threats and held 3 hearings. In the first hearing, we heard from experts about the problems we face due to our massive over-reliance on foreign-made generic drugs. We heard horrifying stories from a former FDA inspector about how dangerous and unregulated these drugs from communist China and India can be. And we learned about the tragic deaths caused by failures to make sure the medicines Americans rely on to heal and treat them are actually safe. In the second hearing, we discussed solutions that create safer medicines, secure supply chains so we aren't dependent on adversaries like communist China for our medicines, and create good-paying American jobs by bringing back drug manufacturing back to America. And in the third hearing, we heard from American drug manufacturers about the hurdles they face when they try to ramp up domestic production. What we uncovered during this investigation will shock you. 91% of prescriptions in the United States are generic drugs. Of those drugs, almost 94% use APIs produced and processed overseas in factories predominantly in communist China and India that have little to no FDA oversight. When the FDA does make it abroad to inspect these facilities, they often warn them in advance, which gives them time to cover up any outstanding issues before inspectors see them. That's crazy. Somehow, even with all this time to prepare, we still see reports of skittering lizards and birds flying around foreign facilities. Does that sound safe and sanitary to anybody here? Absolutely not. Here's the deal. We face 2 problems that every American needs to understand. One is that foreign manufactured generic drugs are made with untested and dangerous APIs from countries like India and communist China. That means we can't trust these drugs because we know they are less safe than those made in America. And the second is that fixing that problem is made difficult by our own government bureaucracy that blocks American drug manufacturers and fuels our over-reliance on communist China and India to make generic drugs. We face not just a serious public health risk, but a massive national security risk as well. Think about it. If the government of communist China, a self-described enemy of the United States, or India wants to stop the supply of prescription drugs to the United States, they can do so at any moment. If that happens, the United States has absolutely no plan to keep these generic, life-saving drugs needed by millions of Americans available. This may sound far-fetched, but we're seeing it play out in real time. Communist China has already limited exports of items like rare earth minerals during the COVID pandemic. India blocked the export of critical pharmaceutical ingredients, so it can happen again. If we can't solve this problem, it's only a matter of time before more American lives are unnecessarily lost. We cannot allow that to happen. We must act now. This is why I'm taking action to address these threats immediately with the introduction of my Clear Labels Act. This bill will require country of origin labeling for pharmaceuticals so that physicians, pharmacists, and most importantly, the American families taking these medicines know where these essential drugs are coming from. Every American deserves honesty and transparency about what they're putting into their bodies. We label food, clothes, and other products, but we don't require that same standard of medicines that Americans, and especially our aging population, rely on. Can anybody really disagree with that? It is wholly irresponsible that we're living in the dark when it comes to where our medicines are made. My bill changes that. Under my bill, finished drug products prescribed and sold in the United States would need to identify the name and location of each, including API's original manufacturer, as well as the packer or distributor, right on the label or through a searchable electronic portal. This is a simple and common sense reform that will bring transparency and accountability to our generic drug industry. The fact is, most Americans would prefer to buy American when they can. Unfortunately, with drugs, too often the information about the country of origin isn't readily available. They want to know what they're taking is safe, and they want to support American jobs. By labeling these essential drugs, Americans will have more information to help them make well-informed decisions for themselves and their families. We'll also encourage more domestic drug manufacturing, making sure generic medicines that our aging population and all Americans rely on are more effective and readily available. Country origin transparency is not just a consumer right, it's a matter of national security, public health, and American pride. And I invite all members of the committee to join me and co-sponsor this legislation. We can get country of origin labeling done now to allow stakeholders at every stage of healthcare, especially the patient, to be confident and informed about the medications they take. I look forward to hearing from witnesses today on how we can empower patients to make the best choices for themselves and their families when it comes to where their medicines come from. Now, I'm going to turn it over to Senator Moody. I have to go to a Foreign Relations Committee for a few minutes, and she'll take over. And she's my colleague from Florida, and as a mom, she has to worry about not only the drugs she puts in her body, of what her kids are putting in their body.
Thank you, Chairman. Good morning. Thank you so much for being here. I'd like to welcome all of our witnesses and everyone that is here today to witness this hearing. Our witnesses are leading experts on generic drugs and generic drug supply chains and can speak to how we ensure Americans have access to medications that are safe and high quality. I'd now like to introduce our first witness, and if you would like to, after I introduce you, go ahead and begin your introduction, and we'll go from there. We'll begin with Dr. John Gray. Dr. John Gray is a Dean's Distinguished Professor of Operations at The Ohio State University's Fisher College of Business. Go ahead.
Chairman Scott, Ranking Member Gillibrand, and distinguished members of the committee, thank you for this opportunity, and thank you very much for bringing so much attention to this.
Well, I am not Chairman Scott. I have more hair than he does. Thankfully.
Slightly more charming.
But go ahead.
I want to start by saying I strongly support giving consumers, doctors, pharmacists, and other stakeholders access to basic drug-level information, including country of origin and some valid assessment of drug quality risk. This kind of transparency would allow generic manufacturers to compete on something other than price, and it could help slow or even stop the race to the bottom that has been present in this industry for the past several years. For many years, the FDA has emphasized that all generic drugs patterned after the same original drug are exchangeable. That may have been largely true decades ago, but today it is no longer a defensible assumption. There is now substantial evidence, both anecdotal and academic, that meaningful quality differences exist among generic drugs. Investigative reporting, academic research, and testimony to this committee have made that clear. These problems are the predictable result of intense cost pressure combined with a highly opaque supply chain, a product where quality is difficult to detect by touch or feel, and, as mentioned, the exchangeability assumption. The FDA's traditional approach to ensuring quality is focused on inspecting manufacturing process to verify compliance with good manufacturing practices. That approach is necessary, but has become much harder as manufacturing has moved offshore, especially when foreign inspections are often pre-announced. From my own experience, 8 years working as an engineer and manager in an FDA-regulated manufacturing facility, I can say that consistent compliance is genuinely difficult. Day-to-day variability in materials, equipment, environments, and human decision-making create constant risk. When firms are under pressure to deliver on time and compete on price, it can be tempting to overlook small compliance issues rather than investigate them fully. Over time, even well-intentioned organizations can go down that slippery slope. Indeed, in my research with co-authors over a decade ago, we found that pharmaceutical compliance tends to erode over time, absent a clear, observable reason to refocus on quality. Transparency can help change this dynamic. A congressionally mandated National Academies report in 2022 recommended country of origin labeling. In our research testing that recommendation, we found that both consumers and hospital pharmacists showed a clear preference for drugs manufactured domestically or nearshore and away from drugs manufactured in India or China, even when told that all drugs were FDA approved. That same report also recommended public-facing quality scores. When we tested quality scores alongside country of origin, we found something important. While consumers preferred domestic drugs on average, high-quality offshore drugs were preferred over moderate-quality domestic ones. This tells us that transparency can promote competition on quality, not just location or cost. While the industry remains opaque, some progress has been made. My co-authors and more recently ProPublica investigative journalists have been able to link many drugs to their finished dosage form manufacturing facilities using mostly public data. These efforts are valuable, but they are incomplete difficult to maintain, and require enormous effort, in the case of ProPublica, even including a lawsuit of the FDA for some data. Critically, even with these efforts, we still lack reliable public data on active pharmaceutical ingredient manufacturing locations. There is real momentum for broader transparency. The FDA has requested the authority to release manufacturing location information in its upcoming authorization. HHS has emphasized radical transparency, and the current FDA commissioner was a leader in creating transparency in hospital quality years ago, as described in his book, Unaccountable. I am part of a Pentagon-funded team developing drug-level quality scores using existing data, while a parallel team is conducting laboratory testing of drugs in the market. These efforts have already identified meaningful variation in quality, and the resulting scores should be available later this year. Variation in manufacturing quality has real consequences for patient outcomes. Research in this area has been slow, not only because supply chains were long overlooked as a cause, but also because linking manufacturers to drugs was previously nearly impossible. But as discussed in your September hearing, and in many recent news articles, low-quality drugs have human consequences. My specific recommendation is this: require a QR code on all public-facing drug packaging that links to a website searchable by NDC, showing the manufacturing locations and both the finished dosage form and the active ingredient, along with a drug-level quality score. The site should also allow the same information for other exchangeable versions of the same drug, enabling informed comparison. For consumer-facing use, quality scores should be designed carefully to avoid discouraging patients from taking necessary medications. One option would be a 5-star scale where all marketed drugs are at least 3 stars. Transparency should be one part of a broader policy approach. I support stronger foreign inspections, increased testing, especially of imported drugs, and consideration of a legally accountable U.S.-based qualified person for imported batches. Federal purchasing decisions that incorporate quality and country of origin would send a powerful signal to the market. Transparency alone will not solve every problem, particularly in the complex private market, but is a necessary foundation. By allowing manufacturers to compete on quality and location and not just price, we can begin to reverse the race to the bottom and improve drug quality for patients. Thank you.
Thank you, sir.
And can speak to drug quality and shortages. Dr. Michael Gonio is Senior Director of Pharmacy Practice and Quality with the American Society of Health System Pharmacists, or ASHP. ASHP is the largest association of pharmacy professionals in the United States, representing its 65,000 members in hospitals, ambulatory systems, and health system community pharmacies. ASHP also maintains a drug shortages list and has worked with Congress and a variety of stakeholders on supply chain resiliency. Thank you for being here, and you can begin your testimony.
Thank you, Senator Moody, Chairman Scott, Ranking Member Gillibrand, Senator Johnson, and members of the Special Committee on Aging. Thank you for the invitation to today's hearing. ASHP appreciates the Special Committee on Aging's comprehensive work over the past several months on creating a more resilient and reliable drug supply chain. For over 20 years, ASHP has worked to strengthen the drug supply chain by publicly reporting drug shortages, providing resources to support patients and clinicians who are affected by supply disruptions, and advocating for policies that support a more reliable and resilient drug supply chain. Every American has a right to know where their prescription drugs are manufactured. Today, that information can be voluntarily provided by manufacturers, but it is not required. Drug labels may include a name and address for a company marketing a product, but not the name and address of a manufacturing location. ASHP strongly supports transparency in the pharmaceutical supply chain, including manufacturer and country of origin labeling for prescription drugs. Research that Dr. Gray and I participated in, that he alluded to, and with other colleagues, has shown that patients and pharmacy purchasers prefer to buy drugs manufactured in the U.S. or Canada compared to products from India or China when the country of origin is made available. Disclosure of this information on the label has the potential to realign incentives in the supply chain away from price and may increase market share for products manufactured domestically. Research also conducted by Dr. Gray and other colleagues reveal there may be a correlation between drug quality and country of origin. These studies provide motivation to increase domestic manufacturing and manufacturing in countries with high reliability and FDA accessibility. However, country of origin alone is not a reliable proxy for drug product quality. There are many examples of manufacturers, both domestic and foreign, that have faced quality challenges in recent years. Our research also ignores key factors that affect purchasing decisions in practice. For example, patients will receive a product in an amber bottle that may not have the country of origin on the label. choice is often an illusion. Patients who've received medications in hospitals and clinics and surgery centers the drugs are often prepared and administered without a patient ever seeing the label. I do want to reiterate ASHP's support for this legislation. This is basic information that every American has a right to know, but I urge the committee to consider additional policies to directly incentivize domestic manufacturing, improve regulatory oversight or inspections of manufacturing facilities to ensure Americans have access to high-quality pharmaceuticals. Chronic drug shortages, concern over drug product quality, and threats to national security are all related to the resilience and reliability of our pharmaceutical supply chain. Policies to address each of these risks and vulnerabilities can actually solve multiple root causes and result in a resilient supply chain of high-quality pharmaceuticals that can withstand demand and supply shocks. There are two separate drug supply chains in the United States: brand name single-source products and older generic multi-source products. Financial incentives and challenges separate these two supply chains. Brand name manufacturers have a strong market incentive to invest in resiliency of their supply chains and produce high-quality drugs. However, price erosion and race to the bottom market dynamics result in a brittle supply chain for older generic drugs. For context, nearly every drug on the FDA's 2020 list of essential medicines is a generic. With slim to negative profit margins, generic manufacturers are less likely to invest in resiliency and quality management. Generic manufacturers that are capable and willing to make those investments often lose market share due to drug price competition from manufacturers that are unwilling or unable to invest in resiliency and quality management. The narrow profit margins also result in the offshoring of our drug supply chain, API manufacturing, to countries with cheaper labor and less rigorous regulatory oversight. Without a public mechanism to evaluate quality and resiliency investments, purchasers have no information other than price to leverage when buying drugs. This reinforces the race to the bottom market dynamics and erodes market resiliency, resulting in a fragile supply chain, concerns about product quality, and chronic drug shortages. To strengthen the drug supply chain, ASHP also recommends additional policies that are available in the written testimony submitted to the committee. These policies are focused on improving transparency into manufacturing quality, encouraging new manufacturers and new manufacturing sites, supporting economic stability by encouraging long-term guaranteed volume purchasing contracts, and diversifying the manufacturing base. ASHP greatly appreciates the Senate Special Committee on Aging's leadership in working to ensure American seniors have access to safe and effective drugs. Thank you, and I look forward to today's discussion.
Thank you. Now I'd like to introduce Dr. Stephen Schondelmeyer. Dr. Schondelmeyer is a professor of pharmaceutical economics and management at the University of Minnesota, as well as the director of the Prime Institute, which conducts research on policies related to pharmaceuticals. Through his decades of research experience as a published researcher on pharmaceutical economics and the pharmaceutical market, Dr. Schondelmeyer has conducted research for the Centers for Medicare and Medicaid Services and the Food and Drug Administration, as well as this committee. We thank you for being here today, and we ask that you'll begin your testimony.
Thank you, Senator Moody and Ranking Member Gillibrand and members of the Special Committee on Aging. I'm pleased to be here today to talk about truth in labeling. It's an important topic to our marketplace and to consumers and to healthcare. Historically, we've had drug shortages in the U.S. market. We understand that. We've characterized them, and we're beginning to deal with that issue. Those shortages have occurred for a variety of reasons, including quality issues of drug products and market economics and concerns related to that. However, the advent of COVID-19 made us aware of and brought to the forefront another issue that causes drug shortages and lack of product in the market, and that is geopolitical risk, that the behavior of other countries in the world can affect our access to supply of drugs. And even some countries, in an effort to maintain sufficient supply for their own population, prohibited export of drugs from their country to other countries during the COVID-19 process. And so we've seen now drug supply be used as a weapon or as a leverage in the marketplace, and that could affect the U.S. Dramatically. We are dangerously dependent on foreign sources for our drug supply in the U.S., with India and China dominating the market for active pharmaceutical ingredients and key starting materials. The U.S. healthcare system is quite vulnerable to this geopolitical risk. If a dominant sourcing country decides to withhold drugs from our supply chain, we would face a major healthcare crisis precipitously. So that brings us to the issue of how do we deal with this? We need to change our drug supply system and our shortage issues from a find and fix mentality, that is, we'll wait till it occurs, then we'll fix it, to a predict and prevent. Let's predict where the shortages are going to be and prevent them from occurring in the first place so we don't have people that go without the necessary medications. I think country of origin labeling is an essential foundational component of that process. It's standard practice for many consumer goods. As Chairman Scott pointed out, there's country of origin labeling for food and clothing and automobiles and other things in our consumer goods market. When the American goes to the grocery store to buy a T-bone steak, or they go to the department store to buy a T-shirt, there's a label on the product that tells them where the product really was made, where it was sourced from. And consumers do read and respond to that information and use it. I find it unconscionable, though, that we require transparency for our dinner and for our denims, but not for the critical drugs that save people's lives, cancer drugs, diabetes drugs, and a variety of other medications. Real country of origin labeling for pharmaceuticals must be clear, specific, and transparent. We should know where the drug product was actually made, not just where it was packaged or warehoused or marketed. Clear labeling must disclose two things: the finished dosage product and where it was made, and where the active pharmaceutical ingredient was made. Currently, finding information about where a drug was made by the pharmacist who has to provide that information to the consumer today is very difficult, if not impossible. It often would take a pharmacist, they can go to sources like the National Library of Medicine's Daily Med website, and if they dig around enough, they can find, for some products, the country of origin, but you can't find it for all products there. It's not always there. And it may take up to 30 minutes to find the answer for one drug, and pharmacists can't operate a pharmacy efficiently if they have to spend 30 minutes for each prescription chasing down what's the country of origin. Furthermore, manufacturers hide behind claims of confidentiality. FDA allows the drug company the option to declare that the information of where their product is made is confidential and a trade secret. And I understand trade secrets are important, but a couple of things come to mind that suggest that this may not be as much of a trade secret as we think. For example, the major blockbuster drugs today, like Mounjaro and Zepbound for weight loss and diabetes, are products that are labeled. If you look on the box or the package, it says marketed by Eli Lilly, and that's good. It tells us who marketed it. It doesn't tell us who made it or where it was made. And Lilly may well make them, and from other databases I was able to find that Lilly really does make their products. But what happens is, if you go to Google for the Lilly case and for many other drugs that say it's marketed by and won't tell you where it was made, if you go to Google, you can find press releases from the company announcing their investment in a new production facility, and they tell you where it is and everything else. So what they told FDA was confidential, they turn around and issue public press releases to say, look at what we're doing. And I applaud Lilly for building a new plant in the U.S. But the point is, it can't be confidential if you're giving it to FDA and not confidential when you put out press releases on the same product in the same plant by the drug company itself. So there's a little bit of duplicity in their approach to what confidentiality really is. There's been a recent change in the regulation of consumer product labeling. In June of 2024, the U.S. Customs and Border Protection issued a new regulation, and they shifted their position. They said the consumer is really the patient at the pharmacy, not the pharmacy when it buys it. They used to interpret that manufacturers had to represent to the pharmacy where it was made, but that was viewed as the end consumer. But we all know, if I'm a pharmacist, we work in the marketplace, and we know that the pharmacist is the last point at which the product gets to the patient. The pharmacist is the face of the patient. So I do think there is a proven transparency process, and that's in the country of New Zealand. New Zealand has a process, a public, transparent online website that publishes the API source and the address where it was made in the factory, the finished dose form, and many other things. I encourage you to look. I've given references in my presentation where to find that and look at that and see what's there. And New Zealand's experience has been that transparency has not harmed the commercial interest of companies. 3 things I recommend to Congress. 1, mandate country of origin transparency. We need to amend federal statutes to require country of origin labeling for manufacturers at both the API and the finished dosage form level. Don't allow companies to hide behind that confidentiality claim.
And sir, if you could wrap up your testimony in just 30 seconds, that would be great.
Yes.
Thank you.
Labeling for consumers is not an end unto itself. It's a foundational building block of a broader database that helps the government and the country strategically plan for a secure drug supply and manage it. So labeling for the consumer is important, but building that broader supply is important. In other words, we need to build a market-wide supply map, and I encourage you to look at the United States Pharmacopoeia's medicine supply map, which does that, and Congress needs to engage with and fund building this and bring it within the work of the government. And finally, empowering consumers. The consumer is the ultimate purchaser, and we need to make sure that this law is implemented and enforced, not just passed.
Thank you, sir. Thank you so much. And I'm sure that the questions will elicit a lot more of what you have to say today. We appreciate you. I'm going to turn it over to Ranking Member Gillibrand now to introduce her witness.
Thank you, Chairwoman Moody. I want to introduce Stephen Colville. Mr. Colville is an Assistant Research Director at the Duke Margolis Institute for Health Policy, where he leads the Duke Margolis Revamp Drug Supply Chain Consortium and policy work on other supply chain and biomedical innovation topics. Previously, Mr. Colville served in the White House Domestic Policy Council as Senior Policy Advisor for Medical Supply Chains. You may begin.
Thank you, Ranking Member Gillibrand, Senator Moody, and Chairman Scott, and members of the committee for holding this hearing. I'm Stephen Colville, and as Ranking Member mentioned, I lead the Revamped Drug Supply Chain Consortium at the Duke Margolis Institute for Health Policy. I've seen the drug supply chain from many different angles. I've worked at one of the largest drug manufacturing plants in the U.S., and then on the commercial business side of that drug manufacturer. I co-founded a drug supply chain certification organization where I worked with health systems to help them identify reliable suppliers, and then moved to the policy side where I've served in the White House Domestic Policy Council and then my current role. And throughout all this, one common thread has been obvious. We need to revamp how our supply chain works to better care for patients. And before discussing solutions, we need to identify the distinct yet overlapping problems in the drug supply chain. First, chronic drug shortages. So these occur when a drug is simply not available, usually because of a supply chain breakdown like a manufacturing delay. Second, questions around pharmaceutical quality assurance. This is when a drug is available, but there are questions around if it was manufactured and tested appropriately. Then third, addressing geopolitical and national health security risks from foreign dependency. And fourth, a desire to grow the economy through domestic manufacturing. So as a nation, we obviously need to address all of these. At the Revamp Consortium, we focus on policy solutions to the chronic drug shortages that have been causing devastating impacts to patient care for 20 plus years. We focus where shortages have been most prevalent: inexpensive generic sterile injectables, which are usually administered by healthcare providers, such as in a hospital setting. So generic drug prices are on average about 33% lower in the U.S. than in other high-income countries. Generics are cheap here, yet too frequently not available because the current provider payment system set by CMS and private insurers encourages providers to seek low-cost generic drugs without enough consideration for reliable availability. So providers are not adequately rewarded when they take steps to prevent shortages. However, there is an alternative: aligning incentives to focus more on reliable availability for critical generics. I co-authored a proposal in October on how to make this happen. Our proposal offers up a simplified version of a Medicare incentive payment program, originally outlined in the 2024 Senate Finance Committee discussion draft. The proposal would incentivize healthcare providers to do 2 things. 1, purchase through committed contracting models, and 2nd, identify and purchase drugs that meet reliability or resiliency benchmarks. Addressing chronic drug shortages in this way is clearly aligned with CMS's mission to improve health outcomes. CMS is also well positioned to move the needle, particularly in the inpatient setting, where Medicare and Medicaid together account for about 75% of inpatient days. Since 2023, CMS has taken several actions to incentivize domestic production, including a notice earlier this week, just this week, about a potential upcoming hospital incentive program. CMS actions should also encourage the reliable availability of critical generics by supporting committed contracts and reliability benchmarks. So I encourage this committee to collaborate with the Finance Committee on that. In the meantime, it's great that this committee is considering legislation to make better information available about suppliers. My top priority here would be to kickstart reliability benchmarking pilots. 3 prominent examples of such programs include the Healthcare Industry Resilience Collaborative's Resiliency Badging Program, U.S. Pharmacopea's Resiliency Benchmarking Program, and FDA's Quality Management Maturity Program. These voluntary programs evaluate confidential data about various manufacturer supply chains. They then can communicate findings to the market about the reliability of those manufacturers. Uptakes of approaches like these has been relatively limited, but could be significantly increased through HHS and DoD funding and support. This could also set a foundation for future CMS reform. Regarding pharmaceutical labeling, Americans deserve to know where their drugs come from, and effective labeling changes could, over time, possibly drive some more demand to domestic manufacturers. However, labeling reforms alone are likely to have a limited impact. Many decision makers already know where API and finished dosage forms are made, and patients have limited influence over what drugs are stocked. Also, just because a drug is made in the U.S. doesn't necessarily mean it's always the best choice. Some of the most significant shortages have resulted from manufacturing issues in U.S. plants. Other assessments are also needed, such as from reliability benchmarking programs, like I mentioned. My written testimony provides additional points on how potential unintended consequences of labeling reforms could be mitigated. Before I close, 2 specific considerations on labeling. Place of business may not be the best term to use in labeling requirements, as place of business is not necessarily the same as the location of manufacturing. It may be more beneficial, as FDA requested in their legislative proposals under the prior administration and again in the current administration, to require manufacturers to include in their digital labeling information unique facility identifier numbers for the original API manufacturer and original finished drug product manufacturer. So finally, to summarize, 1, we need to clearly define the problems. 2, I'd focus first and foremost on CMS payment reforms to support committed contracting models between purchasers and manufacturers that meet reliability benchmarks. And 3rd, consider requiring unique facility identifiers to be included in digital labeling information. Thank you, and I look forward to the discussion.
Thank you very much for your testimony. And without any objection, I'm going to let Senator Johnson kick us off with questions.
Thanks, Senator Moody. I supplied plastic packaging materials to the medical device industry for about 30 years. And, fully understand good manufacturing process, GMP's benchmark of that is traceability. We need to know, what rail car, what box of resin produced that roll of sheet stock that went into packaging that particular medical device, okay? Now, that's just for packaging material. So, Dr. Gray, does the FDA not require that level of traceability on drugs? I mean, things that we actually put in our bodies versus just a package that surrounds a medical device?
My understanding is within the facility, they have requirements, GMP requirements like you're talking about. So the manufacturer itself does have to trace lots and things from its suppliers. But, and Mike can help me with this one, but when the hospitals receive the drugs,
They don't have the information, but
they don't have the information.
Yeah,
the buyers don't have the information.
So does the FDA require that traceability back to the precursor chemicals, to the API, to the actual compounding of the drug, to the marketer?
So my understanding is API, yes. Precursor chemicals, no, is my understanding. At least, and I'm not 100% sure on that. But
and anybody who can answer that question, I mean, how critical would it be for us to know where the precursor chemicals come from, or is it okay just to focus on API? Dr. Schodelmeyer.
Yeah, certainly it's important to know where it came from for purposes of, is it quality? Is it a product that we want to put in human bodies in America? But it's also important to know, to see how dependent we are on specific sources of supply and countries of supply. So they may be putting quality product in there, but if we find that 30, 40, 50% of our API supply is from China,
Okay, I got that,
China's
but
our
again,
adversary.
so I understand the supply chain issue, the precursor chemical. What about a quality issue? I mean, do we need to know what that, where that precursor chemical came from? Or can we do the quality check on the API before it gets compounded into a drug?
Well, I would describe it this way. A lot of that is based on voluntary compliance with the Continuous Good Manufacturing Practices Act. It's not required, and FDA doesn't. It's not like a meat packing plant where they inspect everybody, piece of meat.
Mr. Mascagno, you want to answer this again?
Sure.
So it is not required by the FDA?
The key starting materials, no. And to answer your question about quality, I'd be less concerned about the quality and more the national security vulnerabilities associated with it. So the API is tested by manufacturers. They will confirm that what they receive from an API is suitable for production. Anything that's up to that should be okay from a quality perspective, but the vulnerabilities that need to be revealed are important.
We have the 2008 heparin contamination issue. Mm-hmm. Have we done anything to address what went wrong there?
Scientifically, United States Pharmacopoeia revised the monograph for that, so to make sure that testing and over-sulfated chondroitin sulfate would be detected in the assay. From a national security standpoint, that should address if the GMPs are being followed and record keeping is being followed.
So if we, Mr. Colville, you mentioned that U.S. generic drugs are about 33% less expensive than in other countries, first world nation countries. Why is that? Is it just greater competition, or are there rules and regulations in place in those countries that increase that cost of the drug?
It could be a result of incentives in the market. So what are the purchasers incentivized to value? I think in the U.S. there's a emphasis on low cost, which is important, of course, but there's not enough emphasis on other things that are important too. Reliable availability, quality, everything else that goes into the full value proposition for these products.
In general, generic drugs are pretty cheap, correct? Right. I mean, where we have problems with high drug prices in the patentable drugs, until they go off patent and become generic. So when we're talking about, and I think, what Senator Scott is proposing, labeling, I think that's an incredibly important first step. I think all the witnesses are saying that as well. But, there may be rules and regulations in terms of quality and testing and statistical sampling and GMPs and following those things and making those available as well. That would add a price to that. Anybody want to opine in terms of, would that increase prices by 33%? Which still, when you look at the total drug buy in the U.S., we don't have extremely expensive health care here because of drugs. It's a component of it, but it's a small component. So if you want, I personally think most consumers would pay a little bit more to be assured of quality, so they don't die from a heparin contamination or something like that. And anybody want to opine in terms of what the right rules and regulations and laws to ensure quality, how much that would increase the price of generic drugs? Would it be the 33%? Would it double it? Mr. Gagnon, you look like you want to answer.
I couldn't give you an exact number. That would vary by manufacturer. But as you mentioned, and as I mentioned in my testimony, the two supply chains, there's instances where we probably don't pay enough for our generic drugs, and this is the result, questionable quality. But all we have to value when we buy drugs is the price. Everything is pass-fail, which is clearly not sufficient. So if additional information about quality is made available, then purchasers would have a reason to spend 10%, 15% more. We conducted a survey in 2023 and found our members are willing to spend about 10 to 15% more on drugs. You have to look on the other side, the supply chain issues, the shortages, what they cost, over almost $900 million in labor expenses alone, according to a report from Vizient, a group purchasing organization. Our research also shows increased costs of drug supply chain concerns. So if you make that trade-off, pay a little bit more for guaranteed supply chain high-quality drugs, it theoretically could pay for itself.
By the way, I will say that having been a manufacturer who had to follow GMP, got ISO audits every 6 months, it costs a little bit more, but not that much more. What you end up being is just a far better manufacturer. You have high quality, you have higher level customer service, greater reliability, less scrap. So I wouldn't believe any manufacturer, any of these marketers saying, well, it's going to increase our costs dramatically. It really shouldn't. It's just good manufacturing practices that ought to be insisted on. Again, I really appreciate what Senator Scott is doing here with these hearings. Thank you.
Thank you, Senator Johnson. Ranking Member Gillibrand.
Thank you, Mr. Chairman. Dr. Schottelmeyer, we have been talking about, and also for Dr. Colville, we talked about terms of art, that we have to get the terms of art correct. People say marketed for, distributed by, repackaged by. What is the best term of art you want for this labeling? And I'd like all the witnesses to answer this question, but starting with you, Dr. Schottelmeyer.
I think the simplest is product of or made by. And then it should specify, are they talking about the finished dosage form or the API, and both should be disclosed. FDA may well have all of this information and other information on quality, but they either aren't authorized or as a matter of policy don't choose to release a lot of it. And so just having the information at FDA doesn't necessarily improve the quality and the ability of decision makers to make decisions, whether it's the consumer or the prescriber or the pharmacist or the purchaser. They need to know what FDA knows to make those decisions. So made by or product of, an API product of, finished dosage form product of in the country.
Mr. Colville?
And Dr. Schottelmeyer, you're referring to what's on the physical label, which is important, obviously. But I think we also should think about the digital information. You know, we live in a digital world. So what's the information that's provided digitally? And you can have a lot more information that's provided that way. There's limited real estate on these labels. Some of them are really, really tiny. So as I mentioned in my opening remarks, unique facility identifier numbers could be considered to be
I think that would be very
required.
smart for the digital labeling to say
Right.
exactly where the plant was in India or where the plant was in China.
And if that was done, it would all be listed on DailyMed, the database that several others have mentioned. And third parties could easily put together publicly available user-friendly databases where patients and others could easily look up where these drugs were made.
Dr.
I
Gatt?
would quickly comment that I agree that DailyMed's a great source, but if you look at they do have API manufacturer and manufacturer for some products, and they have an entity identifier on there for the ones that are named, but it's pretty complex and consumers have a difficult time sorting out what's there. I included as an appendix to my longer testimony printouts from the New Zealand MedSafe database that report the same information, but it's much more easily understandable by a consumer if they look it up with a QR code or other things. So I encourage you to look at the way it's presented in the New Zealand MedSafe database. It's much more consumer and user-friendly and easier to follow.
Okay, and Dr. Gagnon?
Yeah, I completely agree with both. I agree with both Dr. Schottelmeyer and Mr. Colville. The physical label should be easy to understand and easy to read. It should say manufactured by the name of the facility. But having the unique facility identifiers in a searchable database can help identify vulnerabilities, choke points, things where we're all relying on the same site, where right now it might be under a contract and not necessarily easily discernible. But stakeholders could find out where those choke points are and invest.
Thank you. Dr. Gray?
Finished dosage manufacturing location, active pharmaceutical ingredient manufacturing location should both be on the label. And then I agree with the searchable data, the easy to access database that includes more details on that. And also, as I mentioned in my testimony, quality ratings.
Thank you. In several of the testimonies today, there have been mentions of the data that is collected by the Customs and Border Protection and the Food and Drug Administration when pharmaceuticals are imported into the U.S. However, what is required to be listed on the label by CPB is different than what's required to be listed on the label by FDA. There have also been allusions to country of origin disclosures being voluntary provided rather than mandated by the current CPB regulations. At times, disclosure regulations required by CPB seem to be at direct odds with those by the FDA. For any of or all of the witnesses, how should Congress work to harmonize the information gathered by the FDA and the CBP to ensure that the information received by them is not duplicative, but also provides consumers with clear understanding of product country of origin?
I'll just say quickly, hopefully this will sort of answer your question, that FDA has requested authorization to be able to release bunch of manufacturing location, API, active ingredient, API, finished dosage form, excipients, critical excipients, et cetera. Allowing them to do that, the FDA feels bounded to not be able to do that by company confidential information. So that would align them, I think.
I think as policymakers, you need to look across both the CPB and FDA and what their regulations are and integrate them. This CBP is limited only to imports, so they don't even require listing on the label made in the USA when it is made in the USA, because that's not an import.
I see.
And so that needs to be cleaned up. I think do it under one set of regulations, probably placed at FDA rather than CBP because of that, and then make it really clear what the language is, you know, what goes. As important as the made or manufactured is the preposition that follows it. Made by is different than made for.
Yes, understood.
Very different. And so clear that up and put clear definitions for it. And then also don't allow companies to declare where it's actually made as confidential or trade secret.
Correct.
Declare that's a public information that needs to be disclosed.
Understood. Thank you. Thank you, Mr. Chairman.
Thank you, Chairman Scott and Ranking Member Gillibrand, for convening this hearing to examine what sounds like a very urgent need for transparency in our drug supply chain. Every day, millions of Americans rely on a wide range of medications to maintain their health and quality of life. As parents, we often take prescriptions to the pharmacy and get medications that we then tell our children to take, trusting that there are no quality control issues. So I think this should be a top of mind for every American and certainly every parent. Unfortunately, throughout the hearings that we've had on this issue in this committee on drug supply transparency, it's become increasingly clear there's simply not enough transparency. And what's worse, FDA import alerts routinely cite carcinogenic impurities, falsified batch records, and non-sterile conditions from manufacturers in China and India. Roughly 1/3 of all FDA import alerts target Chinese facilities, and another 16% target Indian producers. Just last year, I and many of my colleagues on this committee sent a letter to the FDA raising the alarm at problems with drug quality due to poor foreign inspections in countries like China and India, who together account for 60% of APIs globally. And that doesn't even include, as we've discussed already, the key starting materials. Many Americans who rely on prescription medications, particularly seniors, which is why this committee is paying such close attention, have no reasonable way to determine where their medications are manufactured, effectively denying them an opportunity to choose American-made drugs. And what we found is that this failure stems from a combination of loopholes and insufficient FDA enforcement, which allows foreign adversaries such as China to exert control over the production of drugs that Americans depend on to stay alive. It is crucial, and what I'm hearing from every witness today, that we take immediate action to increase transparency in our drug supply chain so that consumers can make informed decisions about the medications they use. Important, a study from 2022 found that 83% of top 100 generic drugs consumed by U.S. citizens have no U.S.-based source of active pharmaceutical ingredients. With that said, I would like to turn to one of the witnesses that I had to cut short when we were getting to time limits on introductions. Mr. Schandelmeyer, in your testimony, you wanted to further explain, I believe, about how in New Zealand, they have a model for providing drug supply chain transparency, and that the New Zealand MedSafe program maintains updated information regarding active ingredients, which is available to the public. What aspects of that model would you say are most crucial to be included if the United States were to ever enact transparency measures on our drug supply chain?
The New Zealand system takes their equivalent of FDA, and they collect all of the information we've talked about. Where are the key starting materials from? What are the inactive ingredients? Where's the active ingredient made, and the factory name and address, the finished dosage form, manufacturer name and address, who packages the product, who labels it. Every step along the way is transparent. And for every prescription drug on the market in New Zealand, it's put in a database, and any consumer in New Zealand or the rest of the world can look up those products at the product-specific level and identify where did it come from. We should have nothing less in America. And in fact, if one looks at these days, the pharmaceutical supply system is really a global supply system. We talk about the U.S. drug supply, but if we take that, that's probably 70 or 80% of the world's global supply. So it really is the same system. We need a system equivalent to, and we need to, I applaud FDA and the Daily Med website that's maintained, but it's not nearly as consumer-friendly as New Zealand's system is, and we need to look at, emulate their process, and then make transparent the information that FDA does have.
Do you believe that the New Zealand model for transparency, the things that they have enacted, do you believe that has decreased the amount of contaminated drugs that are consumed by the public there?
I believe it has, and I haven't seen studies from New Zealand about the number and types of shortages, but I think if they were at the same level as we see in the U.S., we would probably have seen studies of that type. I wouldn't draw a conclusion from it yet, but I don't think they have as severe a drug shortage problem as we do in the U.S. for a variety of reasons. And I've talked with the officials at MedSafe in New Zealand, and they say they aren't aware of any commercial problems in the marketplace from making that information public.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Moody. I guess to start, maybe each of you, when we go to the pharmacy and we have a choice between a generic drug and a brand name drug, are they exactly, we're taking the exact same drug? If each of you could respond.
Yeah, generics typically do not follow the same production process. The excipients can be different, and there's a range of bioavailability that's allowed even upon approval. So generics do go through an approval process that is somewhat rigorous and includes in vitro testing on a small number of individuals, but it's a lot less than the original drug. And that's at approval. And then I think what I'm have researched most and thought about is after approval, when the manufacturing facility's been operating for years under light regulation, how things go, how consistent compliance. But no, it's not the same excipients necessarily. It's not the same process. And there's a range of availability.
I agree that they're not the same. However, they should behave the same in the body. So when I talk to my family, I myself, I have no problem taking a generic. I will tell you that if the label shows where it's made, I will opt for domestically manufactured or quote unquote friendshore manufacturing because I'm not sure the quality of where the product is made. However, I don't think there's any issue with generic equivalency. There are, as Dr. Gray mentioned, a battery of tests that are done to make sure that it behaves in the body the exact same way as the brand name product does.
Embedded in your question is, are they the same drug? And what do we mean by drug? On the one hand, a drug can be the molecule, the active ingredient that causes the positive effects in the body that we're after in the healthcare system. But we also use the word drug to mean the drug product. That is the active ingredient plus all of the extra things we added in to make the tablet hold together and to preserve it, the excipients, as Dr. Gray described. So there may be differences in the excipients and other things. Think about it when you are baking cookies. Each cook has their own recipe, their secret ingredient in making their cookies, and they may be a little bit different. They may all taste similar. They may all be chocolate chip cookies, but there are slight differences across them. But they all have the same, they have chocolate chips in them, and they are chocolate chip cookies. So the molecule, I think, is essentially the same in almost all cases. The other things you add into it may differ, and some of those may have an effect positively or negatively on the health of a patient. And our current process of inspecting and evaluating equivalency of products doesn't take into account all of those other things, perhaps as well as it should.
And thank you for the question, Chairman. For myself, I don't have any problem taking generics. These two are the pharmacists, so I, would very interested in, glad that they shared their perspective. I think the most stark difference between a branded drug and a generic drug isn't the chemical properties themselves of the drug, but it's the supply chain, the robustness of the supply chain. A branded drug has every incentive to have redundancy, extra manufacturing capacity, backup plans, buffer stock. They take all these steps to make sure they avoid shortages, whereas generic supply chains are very lean. If there's a disruption in the supply chain, frequently that leads to patient issues and issues with patient care being impacted. So I think that's the most stark difference.
Dr. Gray, would you take, you don't care if it's a generic or branded drug?
At the moment, I don't take any drugs, but I would generally take a generic drug if prescribed, but would try to investigate where it's from. And again, some of my family do, and ProPublica's RX Inspector, which came out just a month ago, allows you to find out where the finished dosage form of your drug is made easily, unlike the Daily Med approach. So I would certainly investigate. I do pay more for brand over-the-counter drugs. I wouldn't take a generic eye drop. It kind of depends on what it is, right? If it's going directly into the bloodstream or the eyes or a tablet. So.
Okay, Dr. Ganio, so do pharmacists know where the active ingredients of the drugs are made, and if so, do they tell their customers?
No, in general, the pharmacist would not know where the active pharmaceutical ingredient is from. It's possible to research and find that, and there's nothing on a prescription label that would tell the patient. I've never been asked as a pharmacist where the API was from by anyone that I've dispensed the medication to.
Can I just say I've asked my pharmacist, and they look at me like I have two heads. So
No, I ask them every time.
Yeah, okay.
So I've done enough ads. They all know who I am. So, and I've told them about our hearings. So they now expect it. So they actually have more information now than before. Mr. Colville, why is supply chain mapping important to country of origin labeling?
Well, a few different reasons. Supply chain mapping would be important because you want to identify if there's redundancy in the supply chain or if there's concentration. If there's concentration, that can cause issues, for example, from a natural disaster or any sort of disruption. So being able to identify where there's diversification versus concentration, and also just identifying vulnerabilities. There's different problems, like I mentioned earlier, different problems that we need to assess. So if you're thinking about national security issues or geopolitical risks, then obviously mapping the supply chain to determine where drugs that are heavily reliant on more adversarial countries are coming from is important.
Dr. Schaldemeier, what country of origin labeling, would country of origin labeling encourage investment in U.S. pharmaceutical manufacturing?
Would it encourage what?
U.S. manufacturing.
I think it will provide some encouragement for U.S. and for nearshoring manufacturing in Canada, perhaps Mexico or our neighbors in Latin America may be encouraged. Issues that come to play, one reason why China and India have become dominant is because they had lower environmental regulations, lower labor laws, and lower pay, and many other restrictions are eliminated in those countries, and the companies take advantage of that and make it, and they also have an economy of scale larger than the U.S. or the Western Hemisphere. And so I think we can overcome those, though, and with advanced manufacturing that is being developed in the U.S., they can make products leaner and greener. And I think we could get to a point where we could compete in the U.S. And in our near-shored neighbors. And recall, Puerto Rico used to be a hotbed of production. It has declined over time, but I think that could be reinvigorated along with other neighboring entities.
Ranking Member Gillibrand, do you have any other questions?
Just a couple more. Dr. Gannon, I want to explore a little bit more about your testimony about supply chain. You specifically mentioned fragile supply chains and the need for buffer inventory to insulate the United States from potential drug shortages in times of geopolitical conflict. Can you discuss some of the national security risks in more detail?
Yeah, I think we've covered some of it today, but thank you for the question. I keep forgetting to unmute my microphone. Thank you for the question. We know, based on data out of the United States Pharmacopoeia, that we have an over-reliance on China for key starting materials, API sources in China and in India also. In the event of escalating trade conflict, in the event of an armed conflict, if China decides to make a move on the Taiwanese territory, for example, and then things escalate, we are extremely vulnerable to sources in China, and they could hold those supplies from the United States, which would cut us off from essential medicines. And so knowing exactly where those vulnerabilities are, the data and transparency only gives you enough to act, and we can't take action until we have that data. So we believe strongly that the transparency to help the United States understand how much we rely on those sources and how to find alternative sources is critical to our national healthcare security.
And we've had a hearing on this topic before, but we talked a lot about FDA's ability to inspect foreign domestic manufacturing process very significantly, creating concerns about oversight and quality of imported drugs. Can you talk a little bit about that? And that's the same question for all the witnesses.
Yeah, I thank you for the hearing in September. I cannot say that hearing did not keep me up at night after hearing testimony about some of the inspections. But this is where I think it's important. Domestic manufacturing is great. FDA has the ability to walk in unannounced. But I also think in other countries that are considered allies, we should be investing in a diverse supply chain, both in the U.S., in other countries where we have vulnerabilities. We have hurricanes here. We have other disruptions that can happen. So more diversity geographically creates a more robust supply chain. So, but incentivizing it in countries where the FDA has that ability to walk in unannounced, I think is important.
Because it was interesting when asked by the chairman, would you guys take generics? You all said, well, if I could figure out where it's from, I would maybe consider that. So obviously for you as the most knowledgeable stakeholders, where things are manufactured is highly relevant to you. And it's highly relevant to me because we don't have the same inspections. So just to close out the testimony, if each of the other witnesses could just add whatever you want to add on these topics. Go ahead, Dr. Gray.
On the inspections, I'd like to also add that one big difference is the legal ramifications for the individuals, the managers, the quality manager, the plant manager of sending adulterated drugs. In the U.S., you can go to jail. If you're out overseas, you can't, right? We can't prosecute. Yep. I think that's another incentive. I think you heard a lot from Peter Baker on the unannounced inspection pilot, and that shows the need to do unannounced inspections globally. I think 3 or 4, I have a research paper now exploiting the current pilot. I think you're aware that the Congress mandated an unannounced inspection pilot in India that began in late 2022. And we're finding, 3 to 4 times more likely to issue a warning letter of the unannounced inspections relative to the pre-announced inspections, meaning things weren't being found. Some of the worst things you read about the last few years were plants that had clean inspections years prior to the unannounced inspection pilot. So I was thinking about that. I'll stop there.
Dr. Schandelmeyer?
Yes, a couple of points I would make. First of all, India is our major supplier of generic pharmaceuticals. And India is certainly, there are good quality products that come out of India. Not all of them, but some of them. One of the issues is India does not participate in the International Council on Harmonization of Regulation, FDA-type regulations. Most all of our other suppliers, including China, collaborate in that. So we should begin to pressure and encourage India to participate in the ICH. Secondly, within India, they regulate manufacturing of drugs, not at the national level, but at the equivalent of the state level. And they have like 40 states. And even within India, they know that some states have pretty poor quality production and others have better quality. So they differentiate internally in the country, yet we don't as a country when we buy from India. So we need to encourage India to step up within their system, the quality, and make it more consistent and uniform.
Thank you. Mr. Colville?
Thank you, Senator. So 2 thoughts from me. The first is you mentioned location of production, and that's an important thing to consider. I think the best thing to address that issue is leveling the playing field. And one of the best things that can be done to do that is ensure FDA has the resources to do foreign inspections at the level that's needed. And then second point is location of production is only one thing that should be considered. You also need to consider reliable supply chains and quality. And so you can do that through reliability benchmarking programs. I mentioned a few examples of programs that are early on in doing that. And then also you could do independent quality testing to ensure a high level of quality assurance.
Thank you. Thank you, Mr. Chairman.
Well, I want to thank each of you for being here. It's been enlightening. Today's hearing made one thing unmistakably clear. Americans are being asked to trust a system that refuses to tell them the truth. We label our food, we label our clothes. When it comes to life-saving medicine, patients are kept in the dark about where they're made. I mean, that doesn't make any sense. This isn't about banning drugs or raising prices. This could actually lower prices for American families while delivering needed transparency and support American jobs. Manufacturing location matters. Oversight isn't equal. Secrecy doesn't protect patients. It protects the status quo and bad actors. Americans deserve to know what they're putting in their bodies and whether their medicine is truly made in America. Honesty and transparency strengthens markets, accountability, and national security. My staff will be reaching out to share bill text with everybody's office in the coming days. I just want to thank Ranking Member Gillibrand. Her team has been great to work with, and this has been a great bipartisan effort to try to come up with a solution that's going to be workable. If any senators have additional questions for the witnesses or statements to be added, the hearing record will be open until next Wednesday at 5 p.m. Thanks, everybody.
Good job.
Let's get a, if you guys
Good
come up, we'll get a
testimony.
picture.
It's a wrap.
I love like part of my team. I was like, can you take it?